Outcome measures are tools for determining the effective change during a healthcare intervention over time. If you were responsible for purchasing the services for a painter who was going to paint the interior of your house, you would want to know about the quality of the service and the cost of doing it. That's where we find value, getting what we want without paying too much for it. Healthcare consumers want the same thing. They want an outcome they desire and expect, and they don't want it to cost too much for them. The role of the patient-specific functional scale can be better understood from this context and will be a valuable tool if used correctly alongside other diagnosis-specific assessments we already use. Our vision is to provide patient-centered care, which suggests that the patient should be the key determinant of what they wish to gain out of our interaction with them. The PSFS is consistent with our organization vision to provide high-value service. We will discuss healthcare value in just a moment. The objectives for this program include the following. The therapist will have a better understanding of the healthcare value equation. The therapist will complete the patient-specific functional scale for each adult outpatient with patient participation in that survey. And the therapist will appreciate the role the PSFS plays in evaluation and reassessment in order to determine necessity of therapy. The healthcare value is the outcome measured by the cost of delivering that outcome. So think about it. If a patient had an 8 out of 10 low back pain and was out of work, and after 30 visits they still had 7 out of 10 back pain and were not working, where is the value? We need to periodically assess and acknowledge whether or not our efforts are positively affecting the patient and their needs. In order to assess that value, we should use more than just a visual analog scale of pain to measure. We could use diagnosis-specific functional scales, and their validity is dependent upon the particular measure. Next, we will introduce the PSFS and then explore its utility in the adult outpatient setting. As part of our overall assessment of patients, we are required to provide meaningful outcome measures. Outcome measurements allow us as therapists to reflect on our clinical practice, which in turn impacts positively on the quality of the service delivered. Two standardized and routine measures frequently used are the PSFS and the Numeric Pain Rating Scale. Both of these scales, by their very nature, are subjective, yet relevant to the patient and their needs. Consider that many diagnosis-specific self-assessments are a combination of pain and disability, such as the Shoulder Pain and Disability Index, or the SPADI. The PSFS is a subjective outcome measure administered by the clinician with the client. Don't just hand the form to the client, but rather complete the form with the client's input. Over the course of an episode of care, these measures are meaningful both to the therapist and the patient. This should be done at the end of history taking, but before a physical examination. This should always be done face-to-face with the client. The clinician will help the client to identify 3 activities which are difficult for them due to their injury or condition. They will rate the activity from 0, unable, to 10, easy, or at prior level of function. For example, a lower back injury. The client may say, I want to return to work. You might follow up by saying, what do you need to do at work that you find too difficult to do now? And that could be a discussion that would lead to one of your functional goals. Another example might be a patient who had a knee replacement. And again, they say, I want to get back to work. You would ask what the barrier is to returning to work, and they may say, I need to be able to drive my own car. These are just examples. It's expected that the PSFS will be used at initial evaluation, progress notes, or reauthorizations, and at discharge. It is better not to remind the client of their earlier responses or in any manner to bias their response on subjective measures. But if there is discord, if there is a disconnect, it's okay, it's appropriate to confront the patient about any inconsistencies to either clarify or determine if there's further causation for that lack of change or that lack of consistency. In the event of an untimely discharge, the PSFS can be utilized by phone for closure if the therapist does have the opportunity to speak with the client. The PSFS is scored by summing the scores of each goal and dividing that by the total number of identified activities. A minimum detectable change is an overall average score move of 2 points overall, or 3 points per activity. The PSFS was developed by Stratford et al. In 1995 in Physiotherapy Canada. When recording the PSFS for a client that needs to lift up to 15 kilograms as part of their work, or who currently has difficulty mowing lawns and remains seated for longer periods of time, this is how it could look. And as you can see, the baseline scores are averaging about a 3.3. By the sixth treatment, they're up to a 5. Remember, the minimum detectable is about 2 overall. And at discharge, it's at 8.6. In EPIC, the PSFS will take up to 3 activity goals and score an average of those 3. If you only use 2, it would average the 2, etc. Ideally, 3 goals meaningful to the patient should be discussed. These activity goals are very important to consider in the development of a therapy treatment plan. You might want to cue the patient to provide a short, medium, and longer-term achievable activity goal to assist with both short-term and long-term planning. If the patient is handed off to another therapist during the course of care, it's important for that therapist to discuss the activity goals to be certain of the value to the patient and the meaning attached to them. Horn et al. 2012 reported in the Journal of Orthopedic and Sports Physical Therapy about their literature review of the PSFS as a clinical outcome tool. They indicated that there's a strong shift in clinical practice towards a patient-focused model of measurement. We have moved from an impairment-based to a functional-based approach in our clinical care, and these assessments mirror that change. As we compete for healthcare dollars, we must continually demonstrate our value by focusing on providing evidence-based treatment approaches which are effective and economical. Of course, as clinicians, we may object to yet another clinical measurement or another form to fill out. That is a fair and valid complaint in this day and age, but it does not excuse our responsibility to provide a complete record of our care via our documentation. As noted earlier, this scale was expanded upon by Stratford et al. In 1995 and has been used in government health programs in Canada and New Zealand as a required measure of progress and meaningful change. In this JOSPT study, evidence for using this tool is incomplete, though modest validation has been noted for many adult musculoskeletal conditions. In no way should this assessment replace any diagnosis or condition-specific assessments, nor should it replace a careful and complete therapy evaluation. But it could be used easily alongside all of that evidence to provide a quick and easy measure of change. Thank you. If you have any questions, please feel free to email any of your managers regarding this.